Welcome back to Critical Thoughts. This is not going to be a video for you if you get triggered easily, if certain subjects are just, you know, kind of on eggshell cracked floors. Detransitioning, an emerging health phenomenon. I am a female to male to female detransitioner. If you're not familiar with me and my story, I have 3 other videos on the subject. This is just a part of a series, Critical Thoughts. It's a Google Doc in the description below. I currently have the detransitioning one, and I also have my last video, which would be about the narcissistic family system. Okay? So, detransitioning introduction, the complex landscape of gender detransition. The phenomenon of gender detransition has emerged as one of the most contentious and poorly understood aspects of transgender healthcare in the mid 2020s. As political battles rage across the United States and other Western nations regarding gender affirming care, particularly for minors, the experiences of those who reverse their gender transition have been weaponized by various ideological camps. The Trump administration's 2025 executive order titled Protecting Children from Chemical and Surgical Mutilation, which prohibits federal funding for institutions that provide or research gender affirming care for anyone under 19, has intensified this debate. This essay employs critical analysis to examine whether detransitioning represents an emerging epidemic with lifelong consequences, or a rare outcome being exaggerated for political purposes. Through examining the available evidence on mental health outcomes, physical health complications, and the socio-political context surrounding detransition, we can develop a more nuanced understanding of this complex phenomenon that acknowledges both the legitimate concerns of detransitioners such as myself, while avoiding sensationalism that might harm transgender individuals who benefit from gender affirming care. Examining prevalence and definitional challenges. The fundamental challenge in understanding detransition lies in definitional inconsistencies and methodological limitations in current research. The term itself encompasses a spectrum of experiences from those who permanently revert to their sex assigned at birth to those who temporarily pause or modify their transition for various reasons. According to the 2022 U.S. Trans Survey, the largest survey of transgender Americans, only 9% of respondents reported having detransitioned at some point, with just 0.36% doing so because they determined that gender transition was not right for them. A 2024 systematic review published in the Journal of Sex Medicine found that detransition rates vary significantly depending on the stage of intervention, ranging from 0.8% to 7.4% before starting puberty blockers to 1.6% to 9.8% for those discontinuing hormone therapy. These statistics suggest that permanent detransition due to changed gender identity remains relatively rare, though precise numbers are contested due to research limitations. The methodological challenges in studying detransition are substantial. As noted in one analysis, only 24% of detransitioners informed their clinicians that they had detransitioned, creating significant gaps in medical understanding of this population. This documentation deficit means that existing studies likely underestimate the phenomenon, but also that our understanding of detransitioners' experience remains fragmented. The terminology itself is contested. Some individuals who seize medical transition do not identify as detransitioners, but rather as having taken a different path in their gender exploration. This definitional complexity is frequently oversimplified in political discourse, where detransition narratives are often instrumentalized to support pre-existing positions on transgender healthcare. Mental health dimensions of detransition. The psychological impact of detransition represents a critical area of concern, with evidence pointing to significant mental health challenges among this population. A 2025 Finnish case series from Helsinki University Hospital reviewed 9 adults seeking medical detransition and found that all had psychiatric comorbidities, including mood disorders, 8 patients, anxiety disorders, 7 patients, and personality disorders, with 5 patients. Crucially, all participants reported childhood trauma, with 6 reporting sexual abuse or rape, and 6 experiencing school bullying. This suggests that for some individuals, gender dysphoria may emerge from unresolved psychological stressors rather than a stable transgender identity, though more research is needed to establish causal pathways. The experience of detransition itself can produce significant psychological distress. Participants in a Canadian qualitative study described feeling excluded socially and felt that their experiences were misrepresented in the press. Many reported suffering adverse impacts from dominant narratives around detransitioning, which often frame the experience either as a failure and mistake or alternatively minimize its significance. This epistemic injustice, where detransitioners' knowledge and experiences are dismissed, compounds the psychological burden of detransition. For those who underwent medical interventions, confronting irreversible physical changes can generate profound regret and psychological distress that may persist for years or even throughout the rest of their lives. It is crucial to recognize that mental health challenges among detransitioners must be contextualized within broader patterns of transgender mental health. The 2024 national survey conducted by the Trevor Project found that 90% of LGBTQIA plus youth reported their mental health was negatively impacted by recent politics, with only half of those who sought mental health care able to access it. Structural stigma and healthcare barriers affect both those who pursue transition and those who detransition, creating mental health vulnerabilities across this gender spectrum, or the gender spectrum. Sorry. Physical health consequences and medical considerations. The physical implications of detransitioning represent perhaps the most concerning dimension of this phenomenon, particularly for those who underwent medical or surgical interventions during their original transition. For individuals who pursued hormone therapy, detransition may involve discontinuing hormones, which can lead to endocrine disruption and its associated symptoms. For those who underwent surgery such as mastectomies, breast augmentations, or genital reconstructions, detransition may involve living with irreversible changes that conflict with their current gender identity, the one they were assigned at birth, perhaps. The Finnish study noted that patients had used hormones for an average of 7 years, with 8 undergoing chest reconstruction augmentation surgery and 4 natal females having reproductive organs surgically removed. These irreversible procedures represent permanent alterations to the body that can have lifelong consequences for those who later detransition. Medical literature remains surprisingly limited on the specific health complications faced by detransitioners. A systematic review of qualitative data found that detransitioners report challenges including social and emotional difficulties, lack of support, negative healthcare experiences, detransphobia, and identity concerns. The same review highlighted that detransitioners have unique needs for psychological support and medical care that are currently not being met by healthcare systems. Particularly concerning are reports that many detransitioners feel they received inadequate evaluation before they even transitioned. 55% in one study of 100 detransitioners felt they did not receive an adequate evaluation from a doctor or mental health professional before starting transitioning. This suggests systemic failures in assessment protocols that may contribute to later detransition. The physical health consequences of detransition must also be understood in relation to the well established benefits of gender affirming care for those who continue their transition. Research consistently shows that gender affirming interventions significantly reduce suicidality and provide long term mental health benefits for transgender individuals. Nearly all transgender youth continue their care into adulthood with high satisfaction rates. Thus, any discussion of detransition's physical health consequences must balance concerns about inappropriate transitions against the demonstrated benefits of appropriate gender affirming care. Political and medical context, weaponization, and care. The politicization of detransition has dramatically shaped both public understanding and healthcare access for both transgender individuals and detransitioners. The Trump administration's directive to the National Institutes of Health to study transition regret came alongside the cancellation of millions of dollars in research grants for transgender health. This political intervention into scientific research has raised concerns about research integrity and the potential for biased outcomes. As Adrian Schenker, former Deputy Assistant Secretary for Health Policy under President Biden, noted, what they're looking for is a political answer, not a scientific one. Not a scientific one, a political answer. That should be an alarm for everyone who cares about the scientific integrity of the National Institutes of Health. The healthcare landscape for gender affirming care has become increasingly restricted, with profound implications for both those seeking to transition and those who are detransitioning. As of 2025, 25 states have enacted blanket bans on gender affirming care for transgender youth, disrupting healthcare access for over 100,000 transgender youth. These restrictions have created significant geographic barriers and financial burdens for families seeking care, with some reporting costs of up to $4,500 every 6 months for medications alone. This restrictive environment may ironically contribute to detransition rates, as the 2022 U.S. Trans Survey found that external pressures like family rejection, 37%, harassment, 33%, and it being too hard to be transgender, 41%, were primary factors in decisions to detransition. The clinical guidance for working with detransitioners remains underdeveloped, leaving healthcare providers without clear protocols for supporting this population. A qualitative meta summary of detransition experiences recommends that psychological support address the complex social, emotional, and identity related needs of detransitioners. Yet, the current political climate has made it difficult to develop evidence based guidelines as discussions around detransition become increasingly polarized between those who weaponize detransition narratives to restrict all gender affirming care and those who minimize detransition experiences to protect transgender healthcare access. Support systems and institutional responses. The support needs of detransitioners represent a significant gap in current healthcare systems and LGBTQ communities. Participants in a Canadian study described limited availability of information about detransition, with resources on how to detransition, particularly from a medical perspective, are scarce. This lack of structured support leaves detransitioners navigating complex medical and psychological challenges with minimal guidance. The same study found that detransitioners often feel caught between hostile agendas. Some gender critical groups seek to capitalize on detrans narratives to discredit all trans identities, they say, while others attempt to keep detrans experiences in the dark to avoid feeding into anti trans rhetoric. The community response to detransitioners has been mixed, with some reporting feeling ostracized from transgender communities after deciding to detransition. One detransitioner participant noted, I guess there are those who try to use detrans people as pawns in the effort to discredit gender transition, which is unfair to both trans and detrans people. This experience of being instrumentalized by various political actors exasperates the psychological distress already associated with detransition. The Canadian study also described what they call testimonial injustice, attacks on the credibility of what detrans youths have to say, with some regarding them as unduly influenced or manipulated, thus negating their ability to choose to detransition in the first place. Healthcare institutions have been slow to develop specific services for detransitioners. The Finnish clinic mentioned in the research results revised its protocols to improve psychiatric screening, facilitate easier re-access for detransitioners without referrals, and emphasize clinical neutrality. Such reforms represent promising approaches to addressing the needs of detransitioners while maintaining access to gender-affirming care for those who need it. However, these institutional responses remain exceptional rather than standard practice, particularly in the current political climate where many healthcare providers fear legal repercussions for offering any gender affirming services. Now, let's get into future trajectories, projecting the path forward to 2000 beyond 2025, 2025 and beyond. I kind of wrote it wrong, I think. From Okay, future trajectories, projecting the path forward from 2025 and beyond. As we look toward the future of detransition in 2025 and beyond, several critical developments will shape this phenomenon. The Supreme Court's decision in U.S. versus Skermeti, expected in 2025 this year, will determine whether state bans on gender-affirming care violate the Equal Protection Clause of the 14th Amendment. This ruling could either exacerbate or alleviate the current patchwork of state-level restrictions that contribute to external pressure detransitions. Additionally, the Trump administration's executive orders targeting transgender rights will continue to influence the healthcare landscape, potentially reducing access to gender-affirming care while simultaneously directing resources toward studying transition regret. The research agenda on detransition requires significant development to inform evidence-based care. Current studies suffer from methodological limitations, including small sample sizes, recruitment biases, and short follow-up periods. Future research should prioritize longitudinal designs that follow individuals throughout their gender journey, including those who detransition and those who do not. Research must also distinguish between different pathways and reasons for detransition to develop tailored support interventions. As one researcher noted, I support rigorous, ethically grounded research into all aspects of transgender health, and that includes the experience of detransitioning. However, it's imperative that such research be framed in a way that neither pathologizes transition nor undermines the overwhelming evidence showing that gender-affirming care is beneficial. The clinical approach to gender-affirming care will likely evolve toward more comprehensive assessment and support models that can reduce inappropriate transitions while ensuring access for those who need care. The Finnish clinic's approach of improved psychiatric screening while maintaining access to care represents one promising model. Developing standardized protocols for assessing comorbidities, trauma history, and social determinants before initiating medical transition could help identify individuals who might later detransition, while protecting access for those who will benefit from gender-affirming care. Conclusion. Towards a nuanced understanding of detransition. The discourse surrounding detransitioning represents a microcosm of broader cultural battles over gender identity, medical autonomy, and evidence-based practice. The available evidence suggests that detransitioning is not an epidemic in numerical terms. Comprehensive surveys indicate that only a small minority of transgender people detransition, and an even smaller subset do so due to genuine change in gender identity rather than external pressures. However, for those who do experience detransition, particularly after undergoing medical interventions, the consequences can indeed include lifelong psychological and physical health challenges that require thoughtful support and care. The current political weaponization of detransition narrative serves neither transgender people nor detransitioners. As one detransitioner participant eloquently stated, I guess there are those who try to use detrans people as pawns in the effort to discredit gender transition, which is unfair to both trans and detrans people. The research community must resist this polarization by conducting methodologically rigorous studies that examine the full spectrum of gender experiences without ideological predisposition. Similarly, healthcare systems must develop more comprehensive approaches to gender care that include robust assessment protocols, support for those questioning their gender, and specialized services for those who choose to detransition. Looking towards the rest of 2025 and beyond, the most ethical path forward requires acknowledging the complexity of gender identity while protecting access to gender-affirming care for those who need it and providing support for those who detransition. This balanced approach recognizes that gender journeys can take many paths without privileging one narrative over others. By embracing nuance, supporting further research, and developing tailored healthcare responses, we can move beyond the polarized discourse that currently dominates discussions of detransition toward a more compassionate and evidence-based approach to supporting all individuals navigating gender identity questions. Thank you for watching this video. Hopefully you don't mind supporting me, as I am a detransitioner myself, currently suffering with a dysfunctional family, born and raised in one, permanent vocal cord changes. I now have to do speech therapy all month of October. Apparently my vocal cords have been stressed out. So hopefully you guys were able to understand me. This has been my take on detransitioning as a detransitioner myself, and we'll see you in the next one.